Hello,
Okay.
Andre. Welcome back to New York.
Yeah, thank you. Hello to everybody. With me is Matthias again.
Hello, Matthias.
Yeah, we have our Iliac case here. Shall I start?
Absolutely.
Very good. Well, maybe you start.
Yeah, of course, yes. So it's a male patient, next slide, with a bilateral common iliac occlusion, PAOD Rutherford 3, severe claudication, both calves. Walking capacity is around 20 meters. ABI, both sides are very reduced. Perform of a TEA on the right groin 2017, and he is a smoker, 50 pack years. Next slide. This shows you the angiogram. You see the very calcified aortas coming down, huge collaterals going down to the leg, and then in the middle you see this occlusion of both sides. It's a little bit kinked, a big amount of calcium there. The groin right side after TAA is open, and left side we have an open runoff down to the foot. Next slide. So far, the steps looks quite easy. Bifemoral access and brachial approach, and then we put in 2 stents.
Well,
nice,
quite honestly, the lesion itself does not look so easy and straightforward. And so I'm missing here my panelists, but in the absence of a panelist, maybe I can ask Jim McKinsey. I mean, with a surgical point, from a surgical point of view, so
Can we go one slide back?
would you consider
No
an
slide.
endovascular approach as well, or
One more.
can we have a mic? Thanks. Jim, why don't you just join us here? Maybe, I mean, they're not.
Yeah, I mean, the same thing that makes it a challenging case endovascular makes it a challenging case surgically. You know, the issue there obviously is a highly calcific vessel. The pelvic perfusion is going to be a concern. I guess it looks like common iliac occlusions. But, you know, this is a patient that would require a aorta bifemoral bypass graft. And again, that's going to be challenging. I certainly would say I would do an endovascular attempt first, try and get through it. And then if for some reason that doesn't work, you can still come back and do an aorta femoral. But my first choice would be endo on this one.
Great. All right, Andre. So I didn't want to interrupt you. So how do you approach that?
Very good. Yeah. Yeah, thank you. So first, once again, a look here to the pre-angio, which we obtained from another hospital. You can see here, well, we also have a CT. Unfortunately, for technical reasons, we cannot show it to you. But I think in this case, the CT is very helpful to measure the diameter of the aorta, to have an impression of the calcium, although you probably, and also in this case, we saw extreme calcium that may lead you to send the patient directly to surgery, although I think also, I mean, no matter how dense the calcium here looks like, especially on CT, we would try endo first. But here on the angio, you can maybe appreciate here the narrowness of the distal aorta. You can see that pigtail catheter coming down on the left side. So pigtail, this is the diameter of 10 millimeter or 12, and we measured in fact 12 millimeter at the distal aorta, distal to that pigtail catheter. So adding to the complexity, I think, of that case, these narrow arteries and aorta here.
Andre,
so
one
we
quick
started
question.
in this kind of...
A quick question for you, Andre. With the more universal use of covered stents now, I mean, I used to be much more concerned about endovascular with these highly calcific lesions before the uniform acceptance of use of covered stents or availability. Has that changed your algorithm, saying that you're not as concerned about the calcium when you can put a covered stent to kind of reinforce it?
Yeah, well, our standard is to use here covered stents, but in fact, I don't think it will help you once you have a perforation. Because, I mean, a covered stent, especially if you take them in a kissing stent-like fashion. If you have, I mean, there will be not a full alignment of the stent graft or the covered stent proximal, neither distal in this severe calcium. So at the end, if you perforate here, it will still bleed. So I don't think it. You should be more aggressive. You should feel safer if you use them. I think it's just the patency rate for these kind of lesions is clearly better with covered stents.
Andre, after you cross it, would you consider doing IVUS and atherectomy possibly, or this is something you wouldn't do?
Well, we personally actually never do atherectomy in iliacs or aorta. First of all, I think it could be potentially dangerous. I don't know. Of course, when you do IVUS, you know where you are. But I think the devices are potentially too small for these relatively big arteries. I don't know. So I don't have experience with this for these. For us, it's ballooning and covered stent.
Yeah, I've IVUS some iliacs, but for occlusive disease, I would not IVUS this, or atherectomize this.
Yeah. Okay, so yeah, maybe we switch to the angio. And here you can see once again the angio. So for these kind of lesions where we expect to be really complex, we actually prefer a 3XS strategy. So coming from the arm, if you try it only from retrograde, you may dissect into the aortic wall, especially if it's that diseased as here. So coming from the arm definitely helps you in this regard. And later on, of course, with covered stents requiring bigger sheaths like 7 French, we implant them. We try to implant them from the groin. So therefore, it's usually also puncture in both groins going up here with 7 French. Yeah, this is once again the angio. You can see here more proximal aorta is bigger. I mean, of course, you can imagine or think that maybe a self-expanding aortic stent for the distal aorta may help to improve the landing zone in this case. Makes the case more challenging, requires 10, 11, 12 French at one side. So we thought maybe in these small arteries, maybe not. And you can see it's very difficult to see here because of all the bowel gas. So yeah, our first step here in these kind of cases, as you can see here, is 6 French above, or from above. If it's not so complex, we may just take a 5 French 90 centimeter sheath down, an angled Judkins catheter to try to get through the occlusion from above, and 2 7 French 25 centimeter sheaths are loaded already from retrograde. Yeah, we started already, and surprisingly, it was very easy here to get the wire through from antegrade into the right iliacs. Actually, on CT, it was not so much eccentric calcium, but more circumferential calcium, but also quite some calcium in the lumen. So therefore, there was indeed a chance to go in through the lesion intraluminal, not around the plaque, between adventitia and plaque. And this is usually our strategy. So with any wire, we try to go through and we snare it here into a guiding catheter coming from retrograde. This is typically a Judkins 6 French guiding, waiting here in the smaller external iliac to take the wire in, push it out, pull it out, and then take a catheter upwards. And that's what we already did. We have now already here this is our quick cross support catheter going over the 018 wire up into the aorta, and then we change here to a supracore wire. That's actually currently where we are. We started already here to try to take the wire here through the left side, but so far, not possible.
So,
yeah, so we have already, yeah.
Andre, what kind of wire was it on the right side which helped you crossing the lesion?
Command 18, yeah, in the past always V18, now it's Command 18. Kann ich einen auch noch dran haben?
So is that the typical way that you're using an
relatively
018 wire system, or could you comment on how you escalate your wire use for such an iliac occlusion?
Yeah, in longer total occlusions in iliacs, we actually primarily start with stiff terumos. However, in fact, really in this aortic bifurcation, we usually start with a straight stiff terum, or something straight to go interluminally through. Or, as in this case, relatively short occlusions, we start with O18 wires. We make a little angle into the tip and try to find a remaining channel here through that calcium. Yeah, so Matthias is trying from retrograde. I will load a wire from antegrade with a torquer. And let's see. But here you can see it's really quite calcium here.
No.
Ich glaube, vielleicht mehr auf der Seite, wo ich da.
So it becomes a competition now, who crosses first.
Yeah, this.
Yeah.
Yeah, exactly. Yeah, and so I have a Judkins right 6-French guiding catheter from above, loaded a 5-French Judkins catheter, so 2 angled catheters to give me a good angle here into that plug here. Matthias, you won. Very good. Perfect. I think that also looked relatively, benign to the aortic wall. It first jumped into the right area and then jumped easily up. So I think there's not really a risk for dissecting here into the aortic wall. So,
but it's rare that you cross it from.
That's rare, yeah.
I mean, that's
correct,
that's
yeah.
maybe an important
Also
teaching point here.
Sure.
You know, what is the advantage of the transbrachial approach? I mean, the experience is that if you cross such a lesion retrogradely, there's a relatively high risk that you enter with a wire subintimally and then you dissect into the aortic segment. If you come from above, usually at least you are well aligned with your catheter in the area of the aortic bifurcation, and then you may still dissect distally, but it's a bit easier to control.
Nochmal zu den Fünfer.
One other question, Andre, is that
45.
you cross with your command wire, and then you put your 6-French juxt in it, and that really kind of tracked over the O and 8 command fairly easily. Does that raise your concern of soft plaque versus thrombus and potential for embolization during your intervention?
Yes, a little bit. However, from retrograde, from Matthias' direction, it was a 5-French catheter. From the brachial approach, I used 6. So we pushed the 5-French catheter through that occlusion. Nevertheless, you're right. Potentially, that is calcific stenosis with some thrombus on top. So in this regard, what could be safe? Maybe predilation with a relatively small balloon. See how it looks like. And also in this regard, I think taking covered stents later on may help to reduce the risk of embolization. What do you think?
Now you exchange to 035 wires, right? The wires now 035 wires?
Here, so these are now 035 wires. Why? I think very convenient to use them. Since we have pushed through with Judkins 5-French catheter, no concern that we cannot push through a balloon which tracks over an 035. Otherwise, of course, if this would have been difficult, we would have taken a low-profile balloon. And supercore, very stable wire, no risk to lose position during the intervention. Let's go a little closer and ask the patient whether it's painful if we open up these balloons. Mal fragen, ob das wehtut, nicht? So this is only 5 millimeter.
Andre, what do you give for sedation to these patients, especially for this particular spot?
Nothing. Yeah. I think, in fact, we want to know whether it's painful. Maybe sedation is, in this regard, not so safe. We want, so in this area, we balloon as long as it's not severely painful. If it's really becoming quite painful, we stop. Tut das weh? No pain with 5. would have been unusual, that's for sure, yeah. Okay. Yeah, maybe we do a shot now, an angio, to see how it looks like. Whether we should proceed directly now with covered stents or
I pull out the catheter.
take some bigger balloons for predilation.
I mean, I would certainly be
I think it's
interested in
important
going
to know whether.
with covered stents early because of concern for thrombus or soft plaque in there, and just kind of trap it behind it. So, you know, I agree with you. I do an angio now, and if it looks like a good luminal path, I just go straight my covered stents and expand from within those.
Yeah, it's what we usually also do. However, I think, I mean, with stepwise ballooning, it helps you to find the right I mean, of course, you can read the right diameter of your stents from the CT, but at the end, what the patient feels and tells you what he will tolerate is something different. And therefore, the stepwise ballooning may help you to know what you can do in this patient or not. So, of course, if, for example, 6 would be painful now already, we would maybe just take a 7 in. But be careful to take a 7 stent graft in or covered stent, which is known to be able to postulate also maybe to 8 or 9 later on. Okay, nochmal etwas einatmen. Halt, ausatmen. So bleiben, nicht atmen, nicht bewegen. Okay, weiteratmen. Yeah, we think so. Now it doesn't look very thrombotic, rather chronic. Of course, thrombus could be further down.
Anyway, 7 would be maybe a good decision, huh?
Yeah, maybe a 7 live stream to potentially be postulated to 8 or 9 later on. What do you think? Well, usually we try to take 8 millimeter diameter stents in, but here in this case, I'm not sure whether it's so good.
If you have 2.8 in the aorta, it looks small for this, huh?
Yeah. What do you think? Would you always be more aggressive, or?
Andre, is the actual stent device on a 7 and on an 8 millimeter really different, or is it the same stent, just a different platform balloon?
738? 58, huh?
Yes, correct. It's for certain sizes, it's the same stent on different balloon platforms. So yeah, correct. So therefore, we could postulate potentially a 7 then to an 8, definitely.
Yeah.
758.
Yeah.
When would you consider a unibody stent graft as compared to using the standard covered stent?
It's a good question. And Andre, are you going to use a balloon expandable wire band or a live stream?
Actually, a live stream. We think in these kind of kissing lesions with this calcium, we need some good force. Yeah, maybe wire bands would maybe align better to the aorta proximal. But with this calcium, I think no way around a balloon expandable covered stent.
Covera would be also an option.
Yeah, Covera is self-expanding. Oops. The new VBX, of course, from Gore could be a good option. Clearly, which you can also nicely postulate. I think with live stream, nothing wrong with this here.
When would you use a
bifurcated stent graft?
There's a. Go ahead with your comment.
So we were just discussing the use of a unibody stent graft.
Sorry.
Just go ahead. There's a little collision time. Yeah? So Andre, you stop, and our colleague here goes ahead.
This is Rami Tadros, here on faculty at Mount Sinai. I was just asking the question about the use of a unibody stent graft in this kind of lesion or with this kind of bifurcation disease. When do you use that as compared to, say, just using a VBX, atrium, or live stream?
Yeah. Yeah, first of all, I think stent grafts are not really designed for this kind of disease, so I don't think it's a good option for severe calcium. Nevertheless, I think there are cases where it's maybe a good idea. For example, these aortic bifurcations where you have some kind of aneurysm proximal. So clearly in this kind of cases where maybe also the common iliac artery is more thrombotically occluded, aneurysmatic disease, we would use a bifurcated stent graft. Otherwise, in fact, also these total occlusions going up to the ranus, it's rather our way to use two long covered stents like two wire bands or new VBX with a length of 80, both sides, two proximal, two distal. Would prefer, in fact, as with the forces of these balloon expandable stents. Or you take a stent graft in and reinforce maybe the limbs into the common iliacs with balloon expandable stents. That could also be an option. So,
plan to reline it with a balloon expandable stent. So now you're doing kind of double the work. The other concern I have is you had those large lumbars and looked like a very generous IMA, and I don't think I'd want to cover those. So I'd like to maintain some of that collateralization there also as you're doing it. So you're not going to get a short enough AFX to really make that work well. So the other question I have is with these nice, relatively straight iliacs, I think a Livestream is a good one to use. If it was more tortuous, then I definitely would consider a VBX. What's been your experience with VBX in these iliac lesions? Do they have enough radial force or not?
Well, we have used them occasionally now. They were not for a very long time available already here in our cath lab, but actually I think it's a good solution. I think the radial force is very good of these balloon expandable stents, and as you said, yeah, correct. So if you have an more elongated artery, that is potentially a better solution. I think this is a good command. However, here, as you see, well, a little bit of elongation, but maybe not so much. With regard to the big lumbars and the inframesenteric artery, of course, we first have a look to the supramesenteric artery, and if everything is, not care whether we cover that artery. I mean, it's big because it's necessary as a collateral. Of course, you have a bad feeling closing this, also the lumbars, but at the end, we want to bring the patient into a situation where he doesn't need this anymore, and I think we can do this. You can see here the left colic artery, which is small. So also from the CT, we know SMA is okay. So it's really only because it's a collateral that it's so big. Okay, I think up to Matthias, what do you think? A little higher maybe? Up to that distal portion here of the, like this. Shall I give another shot here through the arm? Just a moment.
Yeah, but maybe.
Yeah. So.
If you go one strut down.
Yeah.
Maybe we can
so maybe
also save
for future interventions, if necessary, if the disease in the aorta gets worse, maybe we want to have them a little lower to then potentially take an aortic stent here into the distal aorta. So therefore, for this reason, we may pull them back a little bit. If you agree. So würde ich machen.
Yeah.
So, okay.
Shall we inject also from the
Yeah, we should check now the hypogastric here on that side.
Yeah.
Perfect position, I would say.
Yeah.
Yeah?
Yeah.
Good position. And the other side.
So maybe left side, you have to pull back the sheath also.
Pull back the sheath a little more.
Also left. Sorry.
Okay,
Also good.
also fine. Okay. Okay, we're ready to take them in. Maybe first left side. What do you think? So we do it.
Let's take care of the left side. Let's take care of the hypogastric again.
Okay, das bleibt stabil.
Okay.
Lass das mal. Mach das. So we take 4 or 3 hands to first inflate the stent a little bit, so that it opens. So Matthias is inflating. I'm ready to, pull or push if necessary, or pull the sheath, as in this case. And now we can leave this here and start to inflate the other one, also up to 4 atmospheres only, and then we do it in the kissing technique. Ja. Fangen. Jetzt kannst du mal drücken im Rücken, nicht? Merken Sie was? Gar nichts, gar nichts? Nix? So we are at 6.
No, I'm at 4.
No pain? I do have some resistance.
For me, it's soft so far.
Constantly
So
ask
actually
the
the 7
patient for
millimeter
pain.
looks like appropriately sized for an initial implantation
That's-
here.
Yeah,
You have the nice calcium to mark where the
Yeah.
wall is.
nix.
Now you can
Good.
feel it. I'm at 10.
Now you feel something at 10 atmospheres, 1, 2, 3. Sometimes our strategy, if we cannot really open our stents here appropriately, if we are not fully happy, we may send the patient home and bring him back after some weeks and then postulate with balloons. Usually we can achieve then, or improve our results with less pain. Mr. Martin. Just a moment. Okay. Da. So, nochmal bitte etwas einatmen, halb ausatmen, so bleiben, nicht atmen, nicht bewegen. Okay, weiteratmen. Yeah, I think it's already quite okay.
Perfect, I would say.
What do you think? Not so bad?
Looks
Would you
good.
I think the enemy of good is better.
Postulate maybe proximal to 820 or? Yeah. We can do another angulation.
Not so bad
I think
as
this is
usually,
important in
Andre,
this
right?
severe calcium sometimes. Yeah.
So Andre, you're talking about proximally dilating with an 8. What is the goal for that if you're really in your distal aorta right now?
Yeah, you're right. I mean, sometimes it's nice to see them flare a little bit into the aorta, because here, for example, you still see, of course, some contrast passing here. Well, the first centimeters has no full wall attachment here, but at the end, you will never achieve this with 2 covered stents, with 2 circles in a big circle. So you should actually not really care about this. No, I think this is okay, huh?
Yeah.
I think it looks great.
Yeah, I think it's a great result, Andre.
Yeah.
Perfect reconstruction, very straightforward.
Okay.
Thank you very much for that.
Fine. Thank you. Thanks.